We will start shortly. We just want a few more people to join us, and we will be starting very shortly.
Hola.
Yes. We'll be starting shortly. We have about 11 participants on the conference. I'm just waiting, maybe if we can get up to 15, but if in the next 2 minutes we'll be starting.
Okay.
Okay, let me start the introduction, and I believe others will be joining us. Good evening, everybody. On behalf of the management of HIC, I welcome everybody to today's clinical conference. And today, one of our consultant physicians, Dr. Rodriguez, will be taking us through the management of a patient with cardiac arrest. And I believe by the end of the presentation, we will all be able to identify patients with cardiac arrest and know what to do, how to manage them, what to do during the resuscitation process, and thereby increasing the chance of survival. And I will also want us to be checking the chat box during the presentation. Maybe we're going to get a link for the CME before the end of the presentation. So, Dr. Rodriguez, you can start the presentation.
Okay, good evening for everyone. Thank you, Dr. Roland. The topic today is going to be cardiac arrest management. So, we need to understand that the cardiac arrest is the cessation of the cardiac activity with vascular collapse due to defibrillate rhythms such as ventricular fibrillation and ventricular tachycardia, or also due to non-defibrillate rhythms such as asystole and pulseless electrical activity too. There is important to note that this is the sudden presentation, and they generally occur in patients with heart and structural or coronary pathologies. This is the sudden cardiac death that responds to cardiopulmonary resuscitation maneuvers with the true return to the spontaneous circulation when the result is positive. So, as the clinical picture, we need to understand that is the sudden loss of alert due to insufficient cerebral blood flow. Sometimes the patient going to refer some palpitations, shortness of breath. Sometimes they're going to refer any discomfort that they're going to show in any case that something happened or something is not correct. So in that case, the cardiopulmonary resuscitation is very important in that case. So the cardiopulmonary resuscitation is performed on people in cardiac arrest, and the most important is to maintain a cardiac output and circulation in order to keep the vital organs alive. Blood circulation and oxygenation is required to transport oxygen to the tissue with the current strategy. What that means? When any person has any cardiac arrest, the most important in that case is to facilitate the oxygen to all the vital organs. About the 25% of the patient that he received the cardiopulmonary resuscitation suddenly, they have a more possibility to return to the spontaneous circulation. It's important to know that to do any cardiopulmonary resuscitation, it's important to have a team. before to this, it's important to know that something like this can happen inside, outside, in any place that is not the hospital. And in that case, it's going to be basic cardiopulmonary resuscitation. Sometimes going to be into the hospital is the most better option. And the principal and the best is in the ICU place. So, so it's very important to understand that depend on the place that you're going to get or you're going to see this problem is the order that you're going to do. The team during this process is very, very important to do it the best to get the cardiopulmonary resuscitation and to get the spontaneous circulation of this patient. Around the world, there is a algorithms that we normally going to use during that case. The most important that we need to understand that at this time, the compression of this patient is very important. The chest compression is important, and we need to be clear that he has to be the good compression. We need to understand the time is very important, and it's very important the airway too. So there is a sequence that we need to understand that we know that the letter A, B, C, D, and E. A, that means with airway. In the airway is the advanced airway management. In that case, we need to apply the endotracheal intubation or placement of a supraglottic device. In the second option, the carnography or carnometry to confirm and monitor the placement of the endotracheal tube is very important in that case. In B, we're going to intervene with breathing. So it's important to get a airway to facilitate the oxygen and the respiration that the patient can do it. C, going to be with circulation. The circulation can be with peripheral access, most better if we have central access, and sometimes the situation is not all the best, and sometimes we need to use the intraosseous access. So in that problem or in that situation, that I say before, the compression is very important. What is the characteristic of the compression? They have to be deeply no less than 5 centimeters, because in that case, we're going to do that normally the heart going to do, and it's not possible in that time. And the other important, we want to get heart rate between 100 and 120 per minute. In that situation, we need the team because everybody we want to work coordinating to do it the best to help the patient to return to the spontaneous circulation. So can be we have to be a team with 2 persons, but sometimes the best option we're going to get 4 persons as a team. Is everybody going to work together? They have to put 1 person that is going to be the leader. So is the person who's going to check up the time? Is the person that he going to do the order? Is the person that he going to do the sequence to do everything? Because no many person is everybody going to take the order. If we don't organize the sequence, we're going to take it those more percent to get true results. So in that case, we need to do cardiopulmonary resuscitation, the reason about 13-2. What that mean? They're going to be 13 compression every, a 13 compression, they're going to be do 2 breathing. You're going to do it all the time. Remember that we don't going to stop. It's important. The only time that you're going to stop is to intubate the patient is the place we give us the possibility to do it and to facilitate the airway and the ventilation. The circulation, because we're going to need sometimes some medication that the patient going to need, and The last time is D is neurological situation, and E, they going to be the exam. This is the last that we're going to do. Why? Because the exam sometimes is that means with exam exposition, because sometimes the patient, for example, have a trauma or any burden or something that he going to help you to identify what is the problem that provokes this situation in this patient. Or in that case, we need to understand that that we do it, but that I say before, we have two types of read that they have the no defibrillate rims and the defibrillate rims. Is when we have in the first time the compression or the cardiopulmonary resuscitation of this patient, and we check in and we're going to see that he has the defibrillator rims. We're going to apply one shock, and immediately we're going to start with the cardiopulmonary resuscitation for 2 minutes more. Is in that case, and we're checking in the monitor, and the monitor going to show us non-shockable ribs. So the principal thing is to apply the cardiopulmonary resuscitation for 2 minutes. And we're going to check in these sequences all the time. Every 2 minutes, we're going to check the ribs, and we're going to know is in any time difference to change or not. And this is the sequence that we're going to do, and we're going to use it in that case. It's important to understand that the blood circulation is the way to receive the enough oxygen that we require to transport the oxygen to the tissue. If we do this process like a team, and everybody going to follow the order that the leader going to show, the result is going to be the best. The statistics are going to show that about the 15% of the patients that is suffering this problem, one part of the situation going to receive by the effective cardiopulmonary resuscitation. And the other percent is going to be to treat the cause that produce in that patient the cardiac arrest. We going to identify different causes. Around the world, we're going to say that we have the H cause, T cause, and others. The H cause we're going to be the hypoglycemia, hypoxia, hydrogenions, hydrogenions, they're going to be the acidosis, and near we're going to be the hyperkalemia or hypokalemia, hypothermia, hypocalcemia, and hypolisemia. The cause of T going to be the toxin, cardiac tamponade, tension pneumothorax, coronary thrombosis. Into that cause going to the most important is the acute myocardial infarction and the pulmonary thrombosis. In that case, we're going to check the pulmonary embolisms and of course the others. And it's not because it's less important than the other, is the pregnant women and the peri-operatory patients. So when we have the patient with this situation, it's important the cardiopulmonary resuscitation, but the second important thing is to identify what specific cause produce the cardiac arrest in this patient. So, E, and to do it the management to get the most better result in that case. So, going to explain about all the causes that produce the cardiac arrest and what is the specific management that we can do it in that case. The first is going to be the hypovolemia, and the hypovolemia is doing to lose blocks depletion of water and electrolytes. The patient who suffer a lot of diarrhea, vomiting, or any bleeding, abnormal or acute bleeding that produce hypovolemia. In that case, it's more easy the management, but going to depend if the patient have any structural pathology associated with the cause that produce the cardiac arrest. So the most important manage in that case is to administer crystalloid solution, about 500 and 1,000 centimeters of crystallized board by peripheral intravenous is the best option. And they have to consider many ways to identify when the patient suffers from hypovolemia. The more easy sometimes is the physical exam, but sometimes if we can't do it, an ultrasound to check up, for example, the collapse of the vena cava, they're going to help you. We're going to see by variation of pulse pressure, the cardiac output, and cardiac index. So they are very important index to identify if the person's or the patient in that case suffer from hypovolemia or not. Other cause is going to be the hypoxia. Hypoxia, they have four mechanisms of hypoxia. The first is the decrease in the inspiratory pressure of oxygen. In that case, we're going to get some patient that for example, in high altitude or in environment with the oxygen is less than 25%, such as the patient that he is, or the person that he is at the confined space, or the patient that he climbed too much and they suffer for this type of the problem. The second is for hyperventilation. In that case, it's for the person who have the depression of the brainstem, such as dropped central alveolar hyperventilation syndromes. Other case is the peripheral neuropathy, such as the Guillain-Barré syndromes, or muscle weakness, like hypophosphatemia or myasthenia gravis. That means if we have a patient that he suffered any disease like this, we can think in maybe there is this possibility that the patient suffer. The most important rim in that type of the patient is the asystole. So when you go this patient, in that case, you're going to think in the first time, so, oh, this patient maybe the rim that she have in this moment, maybe we don't have the monitor yet, but we're going to think it can be a systole. So we're going to intubate the patient, starting the compression, and we're going to do everything. And after that, we're going to check out everything. What is the fourth? The third is the disturbance of diffusion. That means with alteration of the alveolar capillary membrane, such as the sarcoidosis, interstitial fibrosis, interstitial pneumonia, scleroderma, pulmonary involvement disease, such as the systemic lupus erythematosus or Wiener disease, is another of the principal disturbance that the patient is going to suffer. And in the fourth option of mechanism of hypoxia, we're going to be the increased pulmonary shunts, alveolar occupation due to secretion, water, pneumonia, or acute pulmonary edema, or lung collapse, such as the massive atelectasia, is one of the causes that produce these mechanisms in that case. Other cause going to be the hydrogen ions. In that case, we're going to get with an elevated anion gas and with normal anion gas. In the first condition, some pathology that we're going to get this problem going to be diabetes, ketoacidosis, uremic acidosis, lactic acidosis, and the toxin, like methanol, ethanol, aldehyde, or salicylates too. And the second sequential, we're going to get the hyperchloremic acidosis, with generally associated with extrarenal loss of bicarbonates. In that case, with the patient who suffers for a lot of diarrhea, what is the principal management in that case? So we need to stabilize the balance acid base is the most important. How can I get that? We're going to get the blood to analyze what is the gas, and we are analyze the electrolytes too. And in that case, if the patient have pH less for 2.7, 2.2 or less, or the bicarbonate is less than 8 or equal than 8, this patient, they need to apply bicarbonate because your blood is going to be very acid. And in this situation, any medication that you're going to apply don't going to work properly in that environment. So it's very important to stabilize this, and after that to provoke or to attack or management most better in that patient. In the hydrogenation, you're going to get the hypokalemia and the hyperkalemia too. In the case of hyperkalemia, what is the most important was to stabilize the bond, sodium-potassium bond. The balance of this bond is that they're going to stabilize the hypokalemia, and everybody knows that the principal cause of any cardiac arrest is the alteration of this type of electrolytes. In the case that potassium is very low, we need to administer potassium as soon as possible by an infusion. If we don't treat the cause, we're going to do any cardiopulmonary resuscitation, you're going to apply any medication, wherever that you think that you're going to do. But if you don't stabilize and take it off the cause, you're not going to get the principal result that you need to get in that case. It's the same with hyperkalemia. What is the difference with this situation? That sometimes the principal cause of this problem is for any acute renal failure or any metabolic acidosis or something that produces the high potassium. And in that case, we need to identify what is the cause that produces this problem. Sometimes the patient who's on some beta blockers, so we need to apply medication to produce or to stop the administration of this medication too. And sometimes when we get the management in that case, sometimes we need to talk with the nephrology because sometimes this person, they need another procedure when we get the spontaneous circulation too. If we get the positive result in that case, the most important is to get the ECG before to identify the cause of the cardiac arrest, but hyperkalemia. We're going to think it maybe to apply any dextrose of insulin. In addition, bicarbonate, because this patient, the majority of the patient, going to suffer from acidosis too. We're going to think in that any other easy way to administer calcium gluconate is possible, and if the patient can get or can receive this medication because it's useful to stabilize the membrane stabilizer. And after that, identify the cause of the hypercalcemia. Maybe the patient needs hemodialysis or something to help you with the problem, because we're going to treat the hypercalcemia, but we need to sometimes take another way to help the patient too. On other cause of cardiac arrest is going to be the hypothermia. In that case, for hypothermia, the patient going to suffer when we have simple hypothermia. The patient sometimes going to feeling tachycardia, lethargy, or sometimes alternative bradycardia, absent of pupillar reflex, and in the severe cause can produce hypotension, pulmonary edema, arrhythmia. And if we're going to get any samples in the laboratory, we're going to find rhabdomyolysis, lactic acidosis, coagulopathy, and infection. What happened in that case? So the most important is to get the best temperature of the patient. What is the best temperature of this patient? We're going to get between 32 degrees and 36 degrees. How can we obtain this? Well, we can do it the gastric lavage with warm water to get, or the most important and effective way is the method in the use of the extracorporeal membranes. After the problem, we need to maintain the temperature between these 32, 37, because this is the only way to avoid another or any neurological sequels. Because it's patients who suffer for severe hypothermia, something like this going to happen, and we don't take care of this situation before, we're going to get the spontaneous circulation, we're going to maintain the patient alive, but maybe we have to get a patient in coma, and this is not the best option. The best option is to get a strong body to recover all the condition or all the functions too. Other situation is the tension pneumothorax. The pneumothorax can be primary pneumothorax. He's not related with any lung disease. So any person that maybe suffered any trauma or something that produce pneumothorax. And the other is secondary associated with COPD, cystic fibrosis, lung cancer, necrotic pneumonia, or tuberculosis too. In that case, it's very simple. We need to do in the pleural decompression, and we're going to introduce any needle or something in the second intercostal space in the mid-clavicular line. In that case, you're going to introduce any catheter to facilitate the decompression in the emergency situation. But after that, when the patient is going to be better and we're going to get the result that we need or we want to do it, it's important to introduce an endopleural tube is the optional and the definite option in that case, in the same place for definite management in that patient. Cardiac tamponade, most important in HIC. Is the sudden accumulation of approximately about 150, 200, other person they refer about 100 and 150, but more or less is the milliliter that can produce a acute cardiac tamponade, and this problem going to produce a pressure intrapericardial. This is an emergency, and if we don't take any decision, suddenly the patient going to die in the same time. Suddenly cardiac tamponade, and suddenly the patient can die, because this situation going to produce an symptomatology that is going to, we can know this like the bear triage. That would be jugular engorgement, hypotension, and decreased hair signs. Other person, they say silent heart, but it's similar. And it's most important, if we don't take it off all the blood around the heart, the heart don't going to be this enough space to do that your normally function that the heart. And this is the principal organ that moves the blood and the oxygen for everywhere. What is the principal cause in this situation? Can be for virus, bacteria, and fungus. Other situations can be metabolic, like the uremic or myxedema, autoimmune too, and going to be the lupus, rheumatoid arthritis, rheumatic fever, the cancer, that means primary or metastatic cancer, any chronic heart failure to radiotherapy, some drugs or reaction for some drugs, the aortic dissection, that we more know acute myocardial infarction, and the trauma. Any person with chest trauma, the first thing that we're going to think is the cardiac tamponade. So the management is pericardiocentesis, the principle that we're going to do. And we're going, in that case, we're going to do this first, and after that, we're going to doing the resuscitation maneuvers. Is we get the spontaneous circulation, so We're going to talk with the cardiothoracic surgeons because this patient, they need the consideration of this patient to the further evaluation or to better its evaluation in that case. The toxins. Other cause of cardiac arrest is the toxins. And in that case, it's important to administer the specific antidote because it's very important. We're going to mention the general because we have different toxins by animal, by medication. We are different, but we're going to mention the principle that we're going to get in our hospital, maybe in the Caribbean Sea, because it's the place that we are. So in that case, they can be for medication, that mentioning here is the calcium antagonist, and we're going to use the aminopyridine, glucagon, calcium gluconate. If we have intoxication by digoxin, antidigital antibody is recommended in that case. Any intoxication by organophosphate, atropine is the antidote. Benzodiazepine, midazolam, alprazolam, flumazenil is the antidote of the indication. Opioids, naloxone, and carbon monoxide for the oxygen therapy is the most indication in that case. Other cause of cardiac arrest is pulmonary thrombosis. Pulmonary thrombosis, we're going to think in that situation when we have a patient with any surgery. That means a big surgery and a small surgery. The risk is going to be changed, can be high risk, medium risk, and low risk. But every surgery that we're going to get or we're going to receive is any problem that we're going to thinking in pulmonary thrombosis. We're going to thinking in this, a patient who suffer for diabetes mellitus, any chronic disease like high blood pressure too, advanced age, person with obesity, pregnancy, patient with varicose veins, person who taking any oral contraceptive, any pregnant women, or this situation, any postpartum state, thrombolysis, polytrauma, acute myocardial infarction, any accident, all the time we're going to thinking in pulmonary thrombosis. So we going to get other situation, but we're going to think, oh, is the patient coming to us and the patient has, for example, rest greater than 3 days, or if he has any chronic disease like I mentioned, or if he received any surgery, and during this process, he has shortness of breath, any chest pain or discomfort before, and suddenly he has a cardiac arrest, we have to thinking in this condition in the first time. What is the management? Well, the thrombolytis, we have to think in that, but the thrombolytis is not the best option for all the patient. Why? Because if the patient has any stroke, hemorrhagic stroke, or ischemic stroke, that in the last 6 months or any acute bleeding, any recent surgery in every way, any cancer or any lesion in the nervous system, this patient, they don't apply to receive thrombolytic therapy. Because if we put in the balance between the risk and the benefits, the risk is going to be more higher than the situation that in that case the patient had. Other situation is the coronary thrombosis. It's not because it's less important, because it's one of the main cause of sudden deaths. And the management in that person is to focus to the cardiopulmonary resuscitation and the apply of medication. In the post-arrest state, it's important in that case for the ECG. Why? Because if we thinking that the patient have or they suffer any myocardial infarction, that means is the complicated myocardial infarction or something, the patient, they need the admission and the hemodynamic room for coronary angioplasty too. So at the conclusion, we need to understand that the principal cause of cardiac arrest in that patient is during the asystole and pulse-led electrical activity. And in that situation, we need to understand that the most important focus is the chest compression. The king of the medication that we're going to use with the cardiac arrest is the adrenaline. We're going to use lidocaine, we're going to use amiodarone in any case, but the most important that we can use wherever any cardiac arrest that the patient suffers is the adrenaline. So we need to understand this, and we need to know the dose of this medication too. So identify the cause, that means the S cause, T cause, and the other cause, because if we treat the cause, we're going to get more results, and the percent to recover the patient is going to be over than 15%. Many persons that mention that the ultrasound and the echocardiography is important in that case, but if we don't have in the thing a person, we can do it in the same situation. It's important, but it's not the most important situation in that case. Compression, we got to put in the balance between the compression and the ultrasound. Compression is more important that obtain any imaging. Because this situation, if we take it suddenly and we're going to use in a short time, the result is going to be more than another time. So at this time, I'm finished. So if there are any questions, I'm open.
Okay. Thank you very much, Dr. Wilfred, for the beautiful presentation. And in the presentation, she has taken us through what cardiac arrest is, which is the sudden cessation of cardiac activity. And she has taken us through the advanced, the advanced adult cardiac arrest algorithm, taking us through the non-shockable parts and non the shockable part, and exhaustive discussion on the reversible causes of cardiac arrests, how to identify them, and how to treat them. And before I continue about the comments, the link for CME is in the chat box, which we are expected to fill. Be doing this before we end the presentation, because the link is going to be inactive after the presentation. So, like I was saying, she has been able to talk about the reversible causes, how to identify them, and what to do on them. And so, the comments I have to make is uh, number one, talking about what we call the chain of survival in patients with cardiac arrest. The chain of survival, these are steps, these are events that improve the chance of getting the patient, making the patient survive, in the patient of cardiac arrest, and being able to restore um, spontaneous circulation. And here, today, our emphasis, we're talking about in-hospital cardiac arrest. And so this series of events starts from what we called monitoring, prevention, and early recognition of patients that are prone to developing cardiac arrest. So in the hospital, improving the chance of survival of patients with cardiac arrest starts from identifying high-risk patients, preventing the cardiac arrest from happening, and also early recognition when patient, because like she has mentioned, time is of essence in this group of patients. The quicker we're able to respond to this patient, the higher the chance of survival, and be able to return, get your spontaneous circulation back. So prevention, monitoring, and early recognition, that involves you taking special interest in high-risk patients, frequent ward rounds instead of just maybe once a day ward round. You have to see them often, The nurses have to monitor them more closely and be able to address, identify when things start changing. Oxygen saturation dropping, pulse rate going down, blood pressure going down, respiratory rate going down. Like we used to say, pulse rate of a patient will not just drop from 100 to 20 in a second. There would have been something is happening which we can pick. We may also be able to identify some of the reversible cause. The Dr. Rodriguez has talked about patients with electrolyte derangement, patients with acidosis. You have been doing your ABG, you have been checking you have done your D dimer and all of those. You will be able to identify this patient. And she has said coronary thrombosis. Here we're talking about coronary artery disease, ischemic disease, heart disease is the commonest cause for patients with in-hospital cardiac arrest. So we should have been able to identify patients with this and be able to initiate treatments along that line. The next thing in the chain of survival is activation of the emergency response team. And ideally, every hospital should have a team of physicians get ready to attend to these patients as fast as possible. And like I said, the ability to be able to do this as fast as possible, those are the things that increase the chance of survival. And the next thing is high quality CPR. The emphasis is on the high quality. Like she mentioned, the CPR must be well done, push hard, push fast, minimum interruption as much as possible. So you need a team, and that is why you have to have a team, because for you to be able to do this effectively, you need people so that you'll be able to interchange within the team so that one person does not get tired. So you need a team trained to be able to do this effectively. And the next thing is defibrillation as soon as possible. And as you are starting your CPR, you are doing your chest compression, pushing 5 centimeter at 100 to 120 beats per minute. You are allowing complete chest to recoil in between compression. You are minimizing interruption. Somebody is getting the defibrillator. You are checking the reading to know whether it's a shockable reading and a non-shockable reading. If it's a shockable reading where you have your VF or VTAC, then you are able to apply your shock as soon as possible. And if it's a patient where it's a non-shockable reading, we're talking of patients with asystole, pulseless electrical activity, and some patients with profound bradycardia, you continue your CPR. Then you go into your ACLS that involves the medication she talked about. For non-shockable reading, the main medication you have to give is epinephrine, 1 milligram every 3 to 5 minutes, while CPR keeps going on, and you're still checking the reading whether the patient is going to convert to a shockable reading where you're able to apply your shock. And for the shockable reading, you apply your shock, you continue your CPR. The only time you are permitted to interrupt chest compression, like she said, is when you are checking your reading or when you want to administer shock. So the airway is taken care of and you're administering your medication. For the shockable reading, you also start with your epinephrine, and after that, you can introduce amiodarone or lidocaine, depending on what you have. And this is what you continue. And while checking for all those reversible causes to be able to bring bring the patient out of cardiac arrest. And if you are lucky to do that, then you institute your post-resuscitative care to take care of the patient, to maintain the the circulation that you have brought back so that the patient does not go back into cardiac arrest. And like you said, this needs a coordinated team. Somebody needs to be the head of the team that is giving the instruction, because everybody cannot be giving the instruction at the same time. You have the head of the team giving the instruction. You have a recorder that is recording the medication you are giving, that is taking notes of the time. And you have people taking turns to do the chest compression, people handling the breathing. So all this has to be done in an organized manner. And when you finish your resuscitation, you are also supposed to meet as a team to evaluate whatever you have done, whether it's been successful or whether it's not successful. If it's successful, you see what you have done and you'll be able to learn from the success. And if not successful, you learn, you see what you have done, maybe not too good or something that you have done that you will do in the process. That's the purpose of also review what you have done at the end of the whole resuscitation. And still part of the post-resuscitative measure is all the causes that you have identified. You should be able to continue to take care of them. Patients with ischemic disease, those ones that we need to go into the cath lab, coronary angiogram, angioplasty, CABG, all these are parts of your post-resuscitative care to make sure that you're able to maintain the patient and you are able to see the patient through to discharge. So it doesn't just help at finishing your compression and the ECG, the heart rate is back, the blood pressure is going. Because most of the time, if you don't handle your post-resuscitative care effectively, the patient is going to go back to CPR and you end up losing the patient. So, and if the patient that's what you get is mainly bradycardia, then you should remember the use of your atropine. So these are my addition to the presentation, and I want to say it's been a good presentation, and I want to open the floor if there are questions or other contribution from other participants. But I have a question in the chat box. Someone is asking if CPR puts the ribs at risk. Yes, sometimes you can have rib fracture, but by the time the patient is alive, you can always take care of that because the patient is practically dead at the point you are doing the CPR. So you want to bring the patient back, and the fracture of one or two ribs will not be too much a price to pay to get the patient back alive. Also, they said, can non-medical people actually engage in a meaningful CPR in case of cardiac arrest? Definitely. No, I talked about that. So what we've discussed today is mainly in hospital cardiac arrest. But as we know, majority of the cardiac arrest also happens outside the hospital, and that is where we teach the basic life support, which includes the chest compression and the breathing, which can be by mouth to mouth if it's someone close to you. But like she said, the most important part of resuscitation is to be able to do the chest compression very, very effectively, be able to apply the compression at the lower part of the sternum, press hard, about 5 centimeters deep and fast, achieving about 100 to 120 beats per minute. And you want the chest to recoil, you want the chest to come up in between your compression. Doing that alone increases the chance of survival of the patient, even if you cannot administer any breathing. So if you do that, you are able to save the patient, and it's been proven to help when you are only able to do just CPR alone. So it is important. Everybody can do it, whether you are a doctor, nurse, or non-medical. You are able to do that. So I don't know if there's any other question or any contribution from any other person. Dr. Williams, are you there? Do you have any contribution?
Can I ask a question?
Yes, sir.
Thank you. Thanks, Dr. Rodriguez. Great presentation. But this is more kind of an internal question. Since you are a critical care person and this is a very important topic, what's our internal program for ACLS training and continuing education for our clinical staff? Ola, maybe you can address that as well.
Okay, sir. Thank you, sir. For now, there is no formal, or maybe I would say structure program in place. But what we've done more or less has been like some informal training, especially when we have had patients to resuscitate and some post resuscitative meeting which we have had within ourselves. But I think it's something that we need to come up with a structured program so that we can have like a protocol that will be easy for everybody to follow, and we can easily adapt from the adult cardiac arrest program and bring everybody up to speed about it. I think the specific area we need to work on is intubation and intubation especially, and doing quality CPR. And I think it's something we can come up with along with Dr. Garcia and Dr. Rodriguez. So that would be my contribution. Dr. Rodriguez, anything to say about that?
Oh,
Anything to say about that? So, the question Dr. Madhu asked. Hello?
hello, yeah?
Okay, I said, do you have anything to say? He's asking if we have designed any structured program for training HIC staff about advanced cardiac life
Okay,
support.
we are open to training. If anyone they need any training, we can do it. We need some.
So let me make it easier, Dr. Rodriguez. So let me task you with developing a formal training and maintenance program for the clinical staff so that there is an audit process to make sure that everyone's ACLS is always current and that people are being retrained. And then, I know we have that requirement for ACLS certification to be current for all clinical staff. So I'm just going to task you to make sure that that is in place.
Okay, okay. We can do it.
Okay, thank you, sir. Do we have any other question? Okay.
I was just going to say, in terms of CPR, sorry, thanks, Dr. Rodriguez, for your presentation. I caught it late because I had a patient in clinic with me till quite late. But in terms of, I know back in England, it's obviously routine that we have to update or keep updated every 3 or so years. So there's ALS and then advanced life support. And you can even actually become a trainer as well. They do a sort of training course that you can do to become a ALS trainer. But obviously the things that we've already said, early recognition of a cardiac arrest and early treatment is going to increase survival or increase outcome. And of the most favorable one, of course, is someone who has a cardiac arrest taken to a VF or VT, because if it's a coronary problem, you sort the coronary problem out, you sort the arrest out, and improve longer term survival.
Good point.
Thank you, Doctor. Thank you very much. So we appreciate everybody for joining us for today's clinical conference. So, like I said, we need to fill the link in the chat box for us to get your CME sent to you during the week, and early next week we're going to circulate. Okay, we're going to circulate the topic.
I want to meet with Karen and Ade.
The topic for the next topic for the next presentation. So next week Thursday will be another time. We'll circulate the topic early next week. So don't forget to fill the link in the chat box, and see you next week. Thank you very much.
Before you leave, can I just make a small announcement?
Okay, sir. Go ahead, sir.
Just reminding everyone that we have a special conference on June 19. Professor William Ferran, who's the investigator and principal investigator for the FAME3 trial, which I'm sure some of you are familiar with. That's one of the most important landmark trials that just been presented, preliminary data on the ACC. Dr. Ferran will be our guest. He is a professor of medicine at Stanford University in California. He will be presenting detailed data on FEM3 to HIC clinical conference. It will be on June 19. And so we are looking forward to a very exciting and engaging conversation with Bill Ferran on that date, and everyone is welcome to prepare and be ready and enjoy that session. Okay.
Okay, thank you very much, sir. So please let's take note of that. 19th of
June.
19th of June will be the date. So let's put that in mind. 19th of June, that'll be the third Thursday in the month of June, and we'll keep reminding you during the subsequent conference. Thank you very much for joining us today, and we'll see you next week. Have a nice evening.
Nice day.